you, Bhavya. So I will continue with the clinical features and diagnosis of hepatitis. So first of all, the asymptomatic cyst passage is the most common manifestation of amiloid histolytica. In most cases, the infection resolves spontaneously, uncommonly. Maybe dysentery and other invasive manifestations may occur later. So, as Bhavya have said that normally the proposals which enter into the intestinal mucosa are taken enter into the liver also by portal system also. But in case of this infection mainly occurs in case of patients who have lower whose immune system is not well developed or whose immune system is poor. So mainly in immunocompetent patients, the disease will be mainly asymptomatic form. They will not show symptoms. Only in case of people who have lower immune system, they will show the symptoms. And after it has an incubation period of about weeks to months, and about 10% of individuals colonized with amiloid histolytica which develop a symptomatic disease. Then amoebic colitis presents as abdominal pain or tenderness in 80% of the cases with watery, bloody or mucus diarrhea. Some may have only intermittent diarrhea or alternating constipation. Fever is unusual. Then we have fulminant amoebic colitis, which can be associated with profuse bloody diarrhea, fever, widespread abdominal pain, diffuse tenderness, and pronounced mucositis. Toxic megacolon, edema, cutaneous antibiasis, and rectovaginal fistula can occur as complications of intestinal antibiasis. Amoebic liver abscess in about 1% of infected individuals may occur 1 to 2 years after infection. Some individuals have concurrent amoebic colitis. More commonly, there are no bowel symptoms. The child usually presents with fever, with chills, rigor, and right upper quadrant pain of acute onset, that is less than 10 days. Examination reveals that in the patient we will have the patient will be showing a toxic appearance. The right upper quadrant tenderness will be there. Hepatomegaly can be felt. Jaundice is unusual. Cough along with dullness or capitations in the right lung case may be present. Coming to the diagnosis part. Diagnosis of amoebic colitis is established by demonstration of mobile trophocytes in the stool. We take 3 stool samples on the alternative days and then we examine them. But this has poor sensitivity. Presence of ingested erythrocytes within the trophocytes is pathognomic for amiloid histolytica. In cases of a liver abscess, chest radiograph shows elevated diaphragm and pleural reaction of the right side. Ultrasound, CT scan, MRI or isotopes scan can localize the abscess in most cases. Leukocytosis without eosinophilia, mild anemia, raised alkaline phosphatics, and high erythrocyte sedimentation with abnormal CBC matters that you can see. Serological tests are done, which are commonly used for the diagnosis of extraintestinal disease with amiloid histolytica, which helps in differentiating from amoebic from the pyogenic liver disease. The normally serological tests that we do are ELISA, immunofluorescence assay. Then IgG antibodies persist for a year after amiloid histolytica infections, whereas the IgM antibodies indicate presence of the infection. Commonly used serological tests in clinical practice are ELISA, IFF, IgG. Serological response are detected by ELISA against relatives 6 to 12 months after infection. That's why IHS test is simple to perform and doesn't show to be highly specific and sensitive. The test may stay positive for as long as 10 years to make positive delivery, limiting its utility in endemic areas. Immunofluorescence assay test is rapid, reliable, reproducible, and has to be checked endemic liver abscess from non-endemic liver abscess.
pregnancy with diarrhea or when you take control of diarrhea, then how will you differentiate that from other causes?
Yeah.
But patient presents with diarrhea, take control, how will you differentiate and control from other causes?
Patient with MBBS, they can be presented with the complaint of diarrhea. But it is not necessary that only in case of intermediate stomatic infection diarrhea will be there. There can be other diseases also where diarrhea can be seen. For example, if for example,
Treatment of antibiotics. So, as we have seen in the previous slides, we have come to know that the occurrence of antibiotics in children is not very frequent, accounting for 3% of the cases. So, before diagnosing acute anthrax, help your antibiotics and districts. So, the practice of giving anti-antibiotic drugs for all the children presenting with diarrhea should be strong research since antibiotics is relatively uncommon in the children. Fewer drugs introduced in case of allergic colitis or in conservative management of the allergic liver abscess includes the following. So before going to individual drugs, we can have a broad classification of the allergic drugs. We have seen in pharma, we can divide it into two main categories. One can be for the intestinal antibiotics and one can be for the tubular antibiotics. In case of intestinal, we can have either for both extraintestinal and intestinal and only for extraintestinal causes. So the class of drugs includes the microimidazoles and the amides. And for the terminal causes, we can have drugs like dermomycin, iodopamine, and the The drug of choice in case of antibiotics is metronidazole. The dose being around 20 to 25 mg per kg per day in 3 equivalent doses for around a week or 10 days. And the adult dose includes 750 mg 8 hourly. Next drug is timidazole, belongs to the same group of drugs, the nitroimidazoles. Dose being slightly higher than metronidazole, 50 mg per kg per day, but only for 3 days. Adult dose includes 2 grams. And the other groups of drugs among the same classification are the omeprazole, fexinazole, methanol oxide, and alternatives, but they are less effective. As we told about the classification, these drugs do not destroy the cysts. So we have to give some agents, the renal drugs, which can be effective in case of allergic liver abscess or to destroy the cysts of the skin. The drugs include carbamazepine, allopurinol, diloxamide 4A, and the dose of diloxamide being 20 mg per kg per day in 3 divided doses for 10 days. And the other dose is 500 mg twice daily. So in case of permanent amoebic colitis, which is complication of the same, along with perforation, initially it's managed conservatively with addition of antibiotics. Most commonly used is tetracycline, and the radiographic monitoring should be done to avoid any further complication. And if we see it's not resolving, then we ultimately go for the most commonly performed procedure in percutaneous catheter drainage, either ultrasonic or CT guidance. In case of amoebic tumor abscess, there is a sequence of procedures that we can follow. The first, in uncomplicated cases, we go for the conservative management with the drugs. If the amoebic tumor abscess is ruptured with the peritoneum, then we can go for conservative along with the drainage, but it is the drainage. And if the therapeutic image shows, also we can go for therapeutic image estimation, as I mentioned about ultrasonography estimation. It's not done, but it's reserved for the following cases. First of all, is a diagnosis uncertainty, where the parallel abscess or a secondary infection is suspected, and if the patient is unresponsive to the conventional therapy, and if the abscess is left low, more commonly left low because it can rupture, as I have already told about very complication is pericarditis. So to avoid that particular complication, we have to go for immediate drainage. And if the size of the abscess is exceeded 8 to 10 centimeters, it can lead to rupture in the future. So because of rupture, if it causes empyema, then we have to go for aspiration or drainage. And we can also go for intercostal test drainage to have better outcome. And if amoebic pericarditis, it requires urgent intervention, and we have to go for again similar continuous drainage. So the preventive temper we have known is most commonly the fecal route. So the standard precaution that we must carry about hygiene includes first of all the water. We should not drink contaminated water. It should be fully filtered. And we have to treat the potentially contaminated water by heating, filtration, fluoridation. But also when we are studying about the epigenesis, we saw that water amoeba are not destroyed by fluoridation or other methods, but by boiling we can destroy the species. And in case of food, we have to consume hygienic food, wash the foods and the vegetables for consumption, and the expression be disposed properly, good personal hygiene, boiling the water as I already mentioned, with 2% solution of iodine, and good hygienic conditions like hand washing, not to swim in recreational waters for 2 weeks after the symptoms, and we have to avoid fecal exposure. Thank you.
intermission. The inclusion के rapidization of 6 to 1 to 2 weeks. Most infection in both children and adults are asymptomatic. Symptomatic infection are more common in children than in adults and usually take the form of taking diarrhea due to sudden onset of explosive vomiting or swimming stools along with nausea and nausea. Others may also have abdominal distension, redness, cramps and high fever. There is no blood or mucus in stool. The illness may last 3 to 4 days and usually self-limiting in normal immunocompetent children. Gradual degree of malabsorption may occur. Some patients may have protracted course due to persistent or recurrent mild to moderate symptoms such as brief episode of loose or smelling stool alternating with constipation. Persistent diarrhea may be seen in 30 to 50% cases. A few children may develop chronic diarrhea, lactose and fat